Thank you for the invitation, and I'm really glad to see hemorrhage on the program. So how do I change here? Oh, I see. Okay. So these are my disclosures. And what I wanted to do, just spend a couple of minutes talking about the pathophysiology of brain injury after intracerebral hemorrhage, how this affects the way we treat our patients and we do clinical trials, then spend a few minutes talking about best care approaches, and hopefully I'll have time to mention a little bit about the IDEF trial, which we concluded. So we all know that the primary injury after hemorrhage is related to hematoma expansion. It can be substantial in almost 1/4 of the patients and can lead to permanent disability and death. And this has been an important target. It's a time-sensitive process, happens within the first few hours. So really, if you want to target hematoma expansion, the treatment will also have to be time-sensitive, like TPA and thrombectomy for ischemic stroke. Then there is the secondary injury, which happens over hours, days, and weeks, and that's what Wendy just mentioned, related to the toxic effects of blood products and secondary inflammation. So, as you can see from the slide here, that everything we do to try to treat our patients or to conduct clinical trials is really targeting one of these mechanisms that I just mentioned, either to try to stop the bleeding or to ameliorate the toxic effects of blood products. This can be done by surgery, as we just heard, or there might be a pharmacological approach. So I want to talk a little bit how we target hematoma expansion. The first thing we do is to try to control the blood pressure. It's the driving force, and it's intuitive to think that reducing blood pressure would help with hematoma expansion. You're all very familiar with two famous trials, INTER-ACT-2 and ATTACK-2, which really aimed for intensive blood pressure lowering during the acute phase of intracerebral hemorrhage. The goal was to reduce the blood pressure from 160 to 170 to 140 or lower. You know that the results were not exactly the same. In INTER-ACT-2, there was a slight benefit in reducing disability, with lowering blood pressure. In ATTACK-2, there was no benefit, and there was some suggestion of harm because of increased serious renal adverse events. However, I think this debate is really unnecessary because we need to look at the hearts of these two trials. And on top, you see INTER-ACT-2, and in blue, you can see the average blood pressure reduction in the group that was a control group. In the red, you see the blood pressure reduction in the group that was subjected to intensive blood pressure lowering. So basically, the average on top was around 150 to 160. In the intensive blood pressure lowering group, the average was around 140. So the trial compared 150 to 160 versus 140. In ATTACK-2, which used nicardipine, a much better blood pressure lowering agent, you can see that on top in the control arm, the average blood pressure was 140. In the intensive blood pressure lowering group, it was 120. So the trial was really 140 versus 120. So INTER-ACT-2 was intensive blood pressure lowering trial. ATTACK-2 was very intensive blood pressure lowering trial. So my take on these trials is that we have one large trial to suggest that lowering blood pressure to 130 and 40 is safe and provides modest reduction in disability. And this is particularly true in patients who have small, deep hemorrhages. These are most of the patients that were enrolled in these trials. If you lower the blood pressure too much, then you don't see any benefit, and it might be even causing some safety issues. The truth is, we don't know what to do with the blood pressure in large hemorrhages. It has not been studied, even though we apply these parameters to patients with large lobar hemorrhages. Even though none of these trials showed that lowering the blood pressure decreased hematoma expansion, this is a meta-analysis that included these two trials and suggested some benefit from lowering blood pressure in reducing hematoma expansion. Most recently, pooled data from these two trials were lumped together and provided some new information about what we should do about blood pressure in our patients. It highlighted the importance of the mean achieved systolic blood pressure, the magnitude of reduction in the first hour, and the variability in blood pressure. And basically what we learned from this analysis is that if you're able to achieve your goal early on and you keep the blood pressure stable, this is beneficial and safe. The problem is if you lower the blood pressure too fast quickly and if there is a lot of variability, the blood pressure is up and down. I want to quickly switch gears and talk about reversal of coagulopathy. We see a lot of patients are anticoagulants. It causes delayed hematoma expansion and increased mortality and disability. And obviously, this is more of an issue with warfarin than with DOACs. So there is a common agreement that if a patient has coagulopathy, then it should be reversed. But there are three questions. When do you do it? How do you do it? And what kind of patients should we do it in? The last question, really, we don't know the answer. This is something that really needs more work and more research. But when do you do it? If the target is hematoma expansion, then it has to be done as soon as possible. If the patient needs to go for surgery, then it has to be done quickly. And how, of course, depends on the agent. So if it's warfarin, you have to give vitamin K. We have a lot of options. But the first choice, I think, should be prothrombin complex concentrate because it can do it quickly. Within 20 minutes, you reverse the INR. And the safety profile is not bad compared to fresh frozen plasma. For the bigger trend, of course, we have a specific reversal agent, Prexapine, that should be your first choice. If you don't have it, then probably FIBA or prothrombin complex concentrate. And then for 10A inhibitors, now we have andexanet. And if you don't have it, then prothrombin complex concentrate. I want to say a word about platelet transfusion, which we still see happen, particularly in patients admitted to neurosurgery. Patients on antiplatelet receive platelet transfusion, but we have learned from the PATCH trial that this does not reduce hematoma expansion, does not reduce disability. As a matter of fact, the opposite. It could be harmful because of the increased incidence of serious adverse event. So it should not be routinely used. Then there is common sense management in the next two slides. These patients need to be cared for in an ICU. We need to watch blood glucose, we need to treat fever, and we need to be watchful for seizures if the patients have change in the level of consciousness that we can't explain based off the hemorrhage. Then, of course, dysphagia screening, preventing infection. Oral care is really important in intubated patients, and DVT prophylaxis. The point I want to make here is that there is urgency in treating hemorrhage patients the same way we treat ischemic stroke patients. This seems to be neglected, and I think we need to change this going forward. Now, I'm going to spend the remaining minutes talking about targeting the secondary injury and our experience from the IDEF trial. So many of you may have read the paper and looked at the abstract, and you see that we did not meet the primary endpoint. And a lot of people probably stopped there and didn't read the paper. So I want to go under the surface and tell you what we have learned from this trial. So the premise of this trial, or the concept, is that hemoglobin degradation products, the predominant component is iron. Iron is toxic to the brain. It leads to Fenton reaction, ferroptosis, and cell death and inflammation. So if we're able to remove iron quickly from the brain, maybe we can decrease toxicity and improve outcome. And the trial looked at the use of an iron chelator called deferoxamine compared with placebo and to look at the effect on outcomes. We use something called futility design, which is very complicated. Unfortunately, the time does not allow me to explain it, but maybe if you have questions, I can answer it later. So what you see here on the left upper hand corner is the primary endpoint, basically looking at the proportion of patients with good outcome at 90 days. We define this as modified ranking 0 to 2. What we wanted to see is the arrow there that you see there. This is the confidence interval. We wanted to see it crossing from the gray to the white. If it crosses into the white, that would be a positive effect. We didn't see this at the primary endpoint on day 90. However, when we looked at good outcome defined as modified ranking 0 to 3, you can see that the treatment was 6% better than placebo. We came very close to crossing the gray area, but we didn't quite make it. When we look at the same outcome, modified ranking 0 to 2 at 6 months, you see that this was a positive outcome and would have been a positive trial. All these secondary endpoints were pre-specified in our analysis, by the way. This is the ordinal distribution of the ranking, 3 months on top, and on the bottom is 6 months. And what you can see, the common odds of good outcome was 10% higher at 3 months, 24% higher at 6 months with treatment with deferoxamine. This is probably the most important thing we learned from the trial. This is the percentage of patients with good outcome at different time points: 7 days, 1 month, 6 months, 90 days, and so on. And the important thing to see is that both curves, whether it's treatment or placebo, is going up. Patients with intracerebral hemorrhage continue to improve over time, and they continue to improve after 90 days, which has been used in many hemorrhage trials as the endpoint. The second thing is that you see the response early on, suggesting that the treatment may have accelerated the trajectory of recovery in these patients. This is important because our guidelines tells you to be aggressive in care for 48 hours, and then after this, it's okay to start kind of applying comfort measures only or withdraw care. I personally think we need to give these patients a chance. It takes a long time for hemorrhage patients to recover, and at least we should give them 2 weeks, if not 30 days, before we start making life decisions. We looked at the extent of improvement in hospital within 7 days in NIH Stroke Scale, and you see rapid improvement with deferoxamine versus placebo. And on the right-hand side, this is the percentage of patients where there is a drop in NIH Stroke Scale greater than 4 points. So the pharmacological approach to target iron toxicity after intracerebral hemorrhage, I think, is promising, and whether it's deferoxamine or something else, I think it could be helpful. I think the benefit is probably modest, and you can see in this table here that even though it's a modest benefit, it's still higher than we have seen in any other trial in intracerebral hemorrhage, including the MISTI subgroup where the hematoma size would reduce to less than 15 cc. Thank you.